Respected chairman of today's session, uh, my respected teachers, colleagues, students, and everyone listening from different places. Today I'm going to speak on cerebral palsy. Before speaking in this session, I must recall the name of my friend, younger brother, my course mate, Dr. Shomirul Islam Babu, Associate Professor of Chittagong Medical College Hospital Orthopedic Department, who lost his life due to this corona. He had pretty interest in cerebral palsy and he tried to develop pediatric orthopedics and cerebral palsy in Chittagong. When I was preparing these slides, every day I would remember him and recall his eagerness to develop this subject in his area, I mean Chittagong. With all respect and expecting for his best after results in the afterworld, I'll start today. So I'm going to tell about cerebral palsy today. Cerebral palsy is one of the most unsolved mysteries in orthopedics and in broader respect, I should say, in the medical science. So what we are going to learn today, what is cerebral palsy, how we can diagnose this, the role of an orthopedic surgeon in treating cerebral palsy. We all know cerebral palsy is treated by many sectors like the doctors, orthopedic surgeons, neurosurgeons, pediatricians, neonatologists, physical medicine specialists. At the same time, it is also managed by the physiotherapist, occupational therapist, social workers, family, everyone. So we'll see today only the role of the orthopedic surgeons, how to examine a CP patient, the surgical procedures, and the results. There are many definitions. I have taken this one, a disorder of movement and posture due to a defect or lesion of the immature brain. Cerebral palsy is the most important cause of disability in children throughout the whole world. There is variable clinical presentations we will see today, and there is no such reliable diagnostic test. We only do it by clinical examination and history. In the history, it has been found in many places, in many histories. 3,002 years old mummy of Pharaoh Sifta of Egypt. His mummy was found, and there is physical evidence that Pharaoh Sifta had cerebral palsy. Hippocrates described a disease which resembles cerebral palsy some 2,500 years back. Roman Emperor Claudius, who lived around 2,000 years back, had cerebral palsy. Dr. William John Little of England in 19th century studied cerebral palsy extensively. From him, it is also known as Little's disease. The worldwide incidence of cerebral palsy is 2 to 3 per 1,000 live birth. In Bangladesh, we don't have such a data. One of the big study was done by Professor Shahnaz bin Tabib, sir, died a few years back. Professor Shahnaz bin Tabib, a very reputed pediatrician who worked in ICMH. In 2005-06, he studied 12,000 children in Narayanganj district in 6 villages, and he found an incidence of 6.1 per 1,000 live birth. BCPR, Bangladesh Cerebral Palsy Register, and probably a non-government organization, they started studying about the incidence in Sirajganj district. They are planning to do it throughout the whole world. They have taken help of ACPR, Australian Cerebral Palsy Register, and their initial study showed a pilot study that this is 3.7 per 1,000 live birth. So if it is even 2 to 3 per 1,000 live birth worldwide, in Bangladesh, probably the incidence of cerebral palsy is much more. We have a population of more than 160 million. There are 3 million children born every year. So the CP could be 6 to 18,000 new CP cases everywhere. And in that respect, there is probably 5 to 10 lakhs of cerebral palsy patients at any time in Bangladesh. And this is a huge number. The types. Spastic is the most common one. Athetoid, ataxic, mixed, hypotonic. These are types depending upon the motor function. Athetoid, you all know that it is involuntary problem, control of muscle, and ataxic, there is incoordination. Depending upon which area are involved, there are diplasics. Usually more lower limbs are more involved than the upper limbs. Hemiplasic, one side is involved. Quadriplasic, all four limbs are involved. There are many others. Monoplasia is described, but some authors used to say that there is no monoplasia. There, some have also described there is whole body involvement and quadriplasia in different ways. So musculoskeletal manifestations, what we the orthopedic surgeons usually deal with, these are spasticity, rigidity, muscle weakness, poor selective motor control, soft tissue and joint contracture, torsional malalignments, and liver arm dysfunction, etc. We'll see today. Etiology: injury or malformation of a developing brain before, during, or after birth that causes CP. It is said that 2% of the cerebral palsy cases could be genetic. There could be prenatal poor myelination. There could be peripheral brain cell death, which is caused by the events around the birth process. And there are some postnatal causes also that can be caused by trauma, infection, asphyxia within first few years of life. That may also cause cerebral palsy. Understanding cerebral palsy. I think most of you know this gentleman, one of the finest pediatric orthopedic surgeon and one of the most reputed pediatric orthopedic surgeon of this world now. And he was the president of Pediatric Orthopedic Society of India, Indian Academy of Cerebral Palsy, Indian Orthopedic Association, Asia Pacific Orthopedic Association, and he's now the president of CICOT. I was very lucky to work with him 1 year in 2008. So when I finished doing a fellowship with him, before leaving, about 7 or 10 days back, before my leaving, I asked him, "Sir, you are doing so many kinds of cerebral pediatric orthopedic cases. Which one you still find difficult?" Let me tell you one thing. When I went there in 2008, after I was working in Nitor as an assistant registrar after my MS completion, and before that I haven't done any or seen any cerebral palsy surgery anywhere. But when I went there, I saw half of the cases are cerebral palsy cases in his center. So I asked him, which sector of pediatrics orthopedics you find still difficult, or you don't like, or you don't do that much. To my utter surprise, he said, "Cerebral palsy. I don't understand cerebral palsy yet." That was what he said in January 2019. I left that place on 18th January, and it was probably around 10th. So one of the pioneers in Indian pediatric orthopedics and one of the reputed cerebral palsy surgeon of this world, he said this: "I don't understand cerebral palsy." So this can be of help. The diagnostic metrics, we have to take the history properly. We have to know the developmental milestones. We have to see the gait. We have to know about the GMFCS FMS scoring. Will come later. Physical examination, and sometimes in rare cases we need to go for imaging. So this may help. The milestones, developmental milestones, a child usually can hold the head or neck around 4 months of age, can sit independently around 6 months of age, can crawl around 8 months of age, can walk around 1 year of age. If there is some delay in these milestones, that may indicate whether there is cerebral palsy or not. The gait, very much important in diagnosing the cerebral palsy. This is observational on the left, you can see, and we do it this way. Observational, we see the gait from the front and from the side. It can be done by videographic examination. Many cameras are set, mobile camera, video cameras, and patient walks, and that can be analyzed. But the most modern is the gait lab, where the 3D analysis is done. We don't have any gait lab in Bangladesh. There are few in India, and this is the best way to analyze the gait of a cerebral palsy patient. There are different types of gait. I can show you some. This boy, he has to move by this kneeling. Look at this boy. It's so difficult for him to walk. And the girl down, she kind of needs a launching pad. And this is kind of circumduction gait. This is a hemiplegic case. Look at this boy. He walks few steps and falls down. He has got ataxia. And here, he needs all four limbs to move. So these are the different types of gaits we face in cerebral palsy. So most common is hemiplegic gait, what we find in hemiplegic patients. And hemiplegic gaits are type 1, 2, 3, 4. Equinus is most of the times true equinus. Type 1 is drop foot type. You can see this is the upper picture is of type 2, where there is true equinus, and there is recurvatum of knee. The knee is in recurvatum because of tight quadriceps. Type 3 is stiff knee gait, where rectus femoris and hamstring both are tight. And type 4, this is more typical. We can see in video a typical hemiplegic gait this boy has, and in picture you can see the upper limb, also the elbow flexed, forearm is pronated. In diplegic patients, again type 1, 2, 3, and 4, and these are more proximal involvement. We can see the this is crouch gait. This is crouch gait. The dorsiflexed ankle, and the ankle touches the floor. And if you look here, this is a typical jumping gait. This is a typical jumping gait. So what is this apparent or true equinus we just told? On the left side of the picture, we can see this girl is in equinus and this boy is in equinus. But on the right, you can see the ankle is in 89.6 degrees or 90 degrees. So actually, this is a apparent equinus. Though the heel is not touching the ground, because of this knee flexion, she is walking this way. So this one, though the ankle is not touching the ground, this is not equinus. This is apparent equinus. But this boy, 170 degree of ankle angulation, this is a true equinus. We need to do for further assessment. These are helpful. This GMFC, GMFCS score, gross motor function scale, the FMS, functional mobility assessment score, and muscle tone. These all are needed. We will not go for everything. GMFC score is one of the best thing that is needed for assessing a CP child, and the GMFC 1 is almost near a normal gait, doesn't need help anywhere to walk or run, and GMFC 5 needs help in every aspect, cannot even move him or herself. So we are going for this poll. Dr. Kaisur Rabbi will, you can see the video our question is, what is this gait? Diplasic, jumping, crouch, or hemiplasic? Kaisurabi, could you start that poll?
Start the poll, please.
So what was that gait? Diplasic, jumping, crouch, or hemiplasic? So, okay, the result is jumping gait for 33% is for jumping gait. There is actually no diplasic gait. Diplasics have different gaits. Someone said 19% said crouch gait and hemiplasic. That was not hemiplasic. 90% said hemiplasic. So stop share results, and we can. Why not moving?
নরমালি যেভাবে স্লাইড মুভ করতেন স্যার সেইভাবে মুভ করতে হবে স্যার।
স্লাইডে একটা ক্লিক করে তারপরে রাইট ক্লিক করুন, রাইট অ্যারোতে ক্লিক করলে হবে স্যার।
Okay, look at the gait. This is a diplasic patient and the gait is crouch gait. You see the ankle is in dorsiflexion and the ankle is touching. So this is our crouch gait. Okay, we'll go for the next slide. So for seeing muscle tone, there are many scales, Ashore scale, Stadio scale. We use the Stadio scale mode. This R1 and R2 is resistant 1 and resistant 2. On the left, you can see we are examining this is ankle dorsiflexion, and the ankle in the knee in extension. We usually push the ankle upwards, and when it blocks, this is resistance 1. And we ask the patient to ease and we push, it comes a little more. So this is resistance 1 and resistance 2. That means we cannot come any further. And this R1, if it is say 40 degree and R2 say 20 degree, this R1 minus R2, this is called the spasticity angle. R1 minus R2 is spasticity angle. With spasticity control, we can come up to this R2, not beyond this. Beyond this, we might need something else. So hip joint examination, how do we do it? Thomas test, we all know. Thomas test, we do it this way. This baby is lying in the bed, and the bed and the angle of the thigh, this is the fixed flexion deformity which we have to deal with. So Thomas test is a very common test. Every orthopedic resident and everyone knows about it. And this is very important to examine a case. And we can again see it by Stahley prone extension test. The baby is taken on the side of a couch with prone, and the hip is, the leg is pulled upwards. When the pelvis will go up, that is the angulation. So Thomas test, we are familiar with Thomas test. We can do that. You don't have to do this Stahley prone test, but this is the angulation between the horizontal and the thigh. This is the fixed flexion deformity of hip. This is hip adductor tightness checking. On the left, we are doing it keeping the knee as far as possible in extension, and the hip in extension, knee in extension. And on the right, we are doing it hip and knee and flexion. If we look on the left, it is about 30 to 40 degree, but on the right side, it has come to about 90, 100 degree or more. So the explanation is this Phelps test on the right side, this Phelps test. When we have flexed the knee, the hamstring, this has become loose. The medial hamstring, I mean the semitendinosus, semimembranosus, and the gracilis that has become loose, and that has helped a more abduction of the hip. So this much of abduction was done by these hamstrings. So let me tell you again, if it is in extension, if we keep it, examine it in extension, and this is done by the adductors and in combination with the hamstrings. And when in flexion, the hamstrings get neutral, that is only done by adductors. So on the right side, that is the adductor tightness, and on the left side, this is adductor plus hamstring tightness. This is very simple. Fixed flexion of knee examination, this we do this way. About 30 degrees of fixed flexion deformity is there of this patient. This is popliteal angle, a very important thing that we have to do for hamstring assessment. And again, like that Turdue test, we have shown the hip and knee is taken in flexion, and we push the knee, and on the left again it is R1, and on the right this is R2. On the left the resistance 1, and on the left we ask the patient, on the right we ask the patient to loosen the limb, and we push, and we can bring up to this much, this popliteal angle. I know these things are a little tricky, and you may feel difficult to correlate all these things. This popliteal angle is again important for knowing the hamstring condition. Popliteal test can be done in bilateral way and the unilateral way. This was the unilateral way when we kept the opposite hip extended, and this one is the bilateral way. This is more specific. This Duncan-Ellie test we all know probably. This we can see by this, the rectus femoris tightness. We take the patient prone on the couch and keep a hand on the pelvis, and we flex the knee. If the rectus femoris is tight, the hip will come into flexion. Hip is in flexion. So this is Duncan-Ellie test. From there, we can understand whether the rectus femoris is tight or not. So for seeing rectus femoris tightness, we do this Duncan-Ellie test. Silver scale test. All the when we all were residents, we used to know that. On the left, you can see we are examining, we are dorsiflexing the ankle with knee as far as possible in extension. And with that, we could bring the ankle only into 40 degree short of neutral. So in that position, the triceps, the soleus and gastrocnemius all are working. And when we have flexed the knee, the gastrocnemius has become loose or neutral, and still some amount of extension is lacking, and this is done by soleus. The previous one was with gastrocnemius. On the left side, this lack of extension is for tightness of gastrocnemius and soleus. And on the right side, when we have flexed the gastrocnemius or neutralized it, the remaining part is due to soleus tightness. So silver skulls test, this is one more important thing we need to know. Now we'll go for the pole 2. Pole 2 will show you one gait and one patient. You need to see what is the diagnosis. This, let me tell you, this is a cerebral palsy case. Now you have to answer whether this is diplegic CP or hemiplegic CP. Paul, Rabi, please. So 100% is for some says it's hemiplegic, 92% for diplegic. So you've got almost half of the participants' answers. So 93% is in favor of diplegic the diagnosis is a diplegic CP. Yes, it is a diplegic CP. This is a diplegic CP. Both the limbs are involved and upper limbs are to some extent. So MRC grading, the Medical Research Council grading, we are all aware of these things about the muscle paralysis. We need to know. I'm not going to explaining everything here, but we need to know whom we are going to operate. If someone has type this MRC grade 2, and if we go for surgery, he will lose more strength, and that will become 1. We cannot. Who is having this 2? We cannot go for surgery in him. The patient has to have some strength, so that after the surgery the patient can work. So adequate physiotherapy is essential. The result is good when there is 4 or 3 like that. If we do surgery with the muscle strength of 2 and 1, they will lose more and the patient will not work. So for this type of patients, we have to send the patient for physiotherapy. With adequate physiotherapy, the patient has to gain some strength, and good results or better results come with 4, 5, 3 like that. There is Kendall scale with 10-point scale that is more important, but we are not. I'm not going to go in detail with that Kendall scale. There are some torsional profiles and liver arm dysfunction. That is also important. These are the difficult things in cerebral palsy to understand. Look here, the femoral anteversion. By this examination, this Craig test, the trochanteric prominence test, we can assess about the femoral anteversion. Patient is taken prone on the table. The knee is held in 90 degree of flexion, and we abduct the hip to such extent when the trochanter feels most prominent. We have to abduct the hip, abduct and adduct the hip, and put one hand in the trochanter and see when the trochanter is most prominent. In that position, the vertical line and line between the leg is the femoral anteversion. In CP, in long-standing CPs, the femoral anteversion can increase. This is tibial torsion test. It is a little easier. Again, the patient is taken prone on the table, and the knee is taken in 90 degrees, and ankle and foot is kept neutral. In this position, the longitudinal axis of thigh is taken. This is longitudinal axis of thigh, and the longitudinal axis of the foot through 2 or 3 by second or third metatarsal, and this angle will say there is some tibial torsion. So in long-standing cases, this anteversion tibial torsion may change, and that may have to be addressed when we do this. We take the decision of surgeries or whatever. Last but not least, these things we have to see: standing, balance, and equilibrium. A patient, if cannot stand and doesn't have equilibrium, with the orthopedic surgeons shouldn't go for surgery in that particular patient. Upper limb, there is again this manual ability classification system with 1 to 6 levels. Again, a good functional hand, upper limbs, can help with good results in a cerebral palsy patient. So in a diplegic patient, with good upper limbs will be helpful after the surgery with holding walkers or whatever. So good upper limb function in diplegic, usually they have is what we have to see. In quadriplegic patients, that's why the scope of surgery is less. Spine we have to see. There could be scoliosis, kyphosis, lordosis, everything. Scoliosis is most common in these cases. And we have to see hip at risk also. One of the most devastating situation in cerebral palsy is hip dislocation. So when the adductors are very tight, there is adductor tightness. The hip could be at, we will see later, hip could be at risk and go for dislocation or subluxation. That is one of the situation. Now we'll go for pole 3. We'll go for pole 3.
Please.
The pole 3 is diplasics usually have low IQ. The question is, diplasics usually have low IQ. Can you go for the pole in 20% cases, in 30% cases, in 40% cases? And the last answer is diplasics usually don't have low IQ. So 63% is in favor of diplasics don't have low IQ, and that is correct. That one is correct. So treating a patient, how do you treat a cerebral palsy patient? It has to be a team approach, starting from the neonatologist who have seen the patient, the pediatrician, and after that physiotherapist, occupational therapist, neurologist, orthopedic surgeons, neurosurgeons, everyone is needed to treat a patient. And this also the physiatrists, orthoticians who makes these braces, special educators, everyone is needed. Like this, you can see this Australian squad. Probably McGrath was bowling with three all in slip. So this has to be a team approach like this. And we have to see the communication of the patient, activity of daily living, mobility, walking, this, everything has to be seen. So what are the treatment modalities we, the orthopedic surgeons, do? What the physiotherapists do, the physiatrists do, what the neurosurgeons do. There is scope of neurosurgery. The dorsal rhizotomy is done by them. So we have summarized it as an orthopedic surgeon. We can go for spasticity. We can use medical medicines like baclofen, Botox, phenol, not used anymore nowadays. Rhizotomy is done by the neurosurgeons, selective dorsal rhizotomy, and this shortening correction, which is done usually by the orthopedic surgeons or us. We use splints, we do stretching with braces and everything, and we go for surgery. So when to go for which treatment? You can see around the age from 2 to 5 or 6, the Botox is used. All through physiotherapy, braces, occupational therapy should go on till the age of 18, 19 of the child. But the Botox is very much useful. Botox is useful throughout the whole period, but mostly useful around the age of 4. And surgery, we do around the age of 7 to 9. Before 7, usually surgeries are not done, because by the age of 7, our child gets the adult gait. So for that reason, this around the age of 7, 8, 9, that is the best time for surgery. But surgeries are done up to 12. In many instances, you can do surgery even later. I have done the oldest patient that was 45 for hip. So what is the role of Botox? Botox is an excellent medicine to control this spasticity. This is given in the hip adductors, and we can move. We are moving, and you can see the needles are moving. So here we can give. Now we are putting that Botox, and this is in long flexors of forearm. So Botox has a very great role. The one thing in managing spasticity in children, but thing is, you probably know the price is very high. The American one that is about 30,000 a vial, and this Chinese one is probably around 20,000 a vial. So it is very difficult to use Botox in countries like ours. What the orthopedic surgeons do. Single, even multi-level surgery is the gold standard. The hemi and diplasics, they respond to surgery best. And the best result comes with the hemi and diplasics. Those with good IQ will follow the advices after the surgery will have good results. Surgery in quadriplasics have limited roles. And post-op rehabilitation are very essential with physiotherapy and braces. So these things we the orthopedic surgeons have to keep in mind when going for a surgery. Single even multi-level release, it is usually soft tissue release, bony release. Usually we do it around the age of 6-7 years. In this age group, bony release, bony correction is rarely needed. Bony correction is done usually above the age of 10. And the muscles we usually do rectus femoris and psoas in hip, knee, medial and lateral hamstring. We'll see some of those pictures. Why this single even multi-level release? When a patient comes this way, it may seem to us the patient has equinus. So what we can do, we can go for, should we go for this triceps release? If we do that without seeing the whole patient, the patient may come this way. And we might think there is hamstring release, hamstring tightness. If we go for hamstring release, it will come this way. That means hip flexion. And again, if we go for hip release, it will come back with stiffly. Once upon a time, the surgeries were done, surgeries were called the birthday surgeries. One muscle group was done in every year. So in that way, it was called the birthday surgeries, one group of muscles in every year. But the trend is now the single level, multi-level, do everything bony or muscle release in single setting and single at one time, and that will give us best results. Many of you know Taral Nagda. Taral Nagda is one of the greatest pediatric orthopedic surgeon from India. He said once to me, you see, Sarwar, these CP surgeries are so simple. Actually, these are simple. We'll show some of those pictures. It is so simple, even a resident can do it. But making the decision is so crucial. Even the most experienced person, experienced surgeon can do some wrong. So we have to remember, we have to examine the patient thoroughly and properly, and then decide about the surgeries. So these are the surgeries we do. Usually we do it with tourniquet. Then with tourniquet, this is easy. You can see the semitendinosus or semimembranosus. We can release this. Without the tourniquet, this will happen this way. The semimembranosus, only the aponeurotic release has been done and muscle has lengthened. This semitendinosus, we have done jetplasty. It again, the fractional release also can be done in semitendinosus or gracilis. Here, the gastrosolius complex, this is Becker's procedure. There are many other procedures. We are more we know about this Balpier's procedure. We can do that. We can do stress procedure. These all things can be done in soft tissue releases. We can do rectus femoris release. When we go for rectus femoris release, we usually loosen the straight head, not the reflected head. And this type of bony surgeries may also need to be done. On the left is the recurvatum of distal femur, and on the right side is bilateral distal femoral shortening osteotomy. On the left side, this recurvatum is more commonly done in hemiplasic patients, so not to lose height of that limb that much. On the right side, these are more done in diplasic cases. By this shortening, we can keep the strength of the muscles, and the muscle release or soft tissue release is rarely needed when we do go for this bony shortening. So some cases, this is a hemiplasic 9-year-old boy. You can see the boy is walking this way. So we did surgery with hamstring release and Becker's procedure, and this is what he was working after 3 months of the surgery. This is a 15-year-old boy, extreme equinus. You can see, if you look there, you can see the extreme equinus of that boy. So it was very difficult for this boy to manage with only soft tissue release. So we had to go for this bony procedure. This was done in foot. With even the Becker's procedure, we could not bring the ankle to plantigrade. Then we had to go for this foot surgery, dorsal wedge osteotomy, and we could bring up to this. And with this, he could at least work this way. Still the upper limb is in problem. He was needed this upper limb later on. So this is a diplegic case, came from Khagachuri. If you look at his gait before surgery, he came around 9 to 10 years of age. He was walking with hip flexion, knee flexion, and some jumping, you can see. And we went for hip release, rectus femoris release. We went for hamstring release and Becker's procedure for Valdes procedure for this boy. And this was after 10 months. And after 2 years, the boy is a little bigger and had much better gait. So this is a in case of diplegic. Sorry. Look at this boy, strong boy with strong upper limbs, 14 years old, and it was so difficult for him to come out of that chair. Get down from that chair was so difficult. So when he came with this iron stool. He used to walk that way. He used to walk that way, and you can see the hip flexion, knee flexion, and the ankle dorsiflexion. So it was very difficult because taking the decision for surgery because his lower limbs were so weak. So we asked him for physiotherapy and went for surgery with caution and said he might need this thing. So he was a little better. He could stand erect and walk, and he later improved a little more. So with this, even with this strong upper limbs, it was very difficult for him. But we took the decision of doing the surgery because he had very strong upper limbs and body. So spastic hip, I just said, spastic hip is one of the most devastating situation where we face trouble. And you can see the dislocating hip. So when we do go for when we understand the hip are at risk, the quadriplegics hip are at risk, non-ambulators who doesn't walk, bedridden, they are at risk. Hip abduction spread is less than 30 degrees, that is at risk. And we have to train this patient. We will show one patient later. So this 15-year-old girl came. This was actually after the surgery. You can see the subluxating hip in the X-ray, and it was painful for her to even move. So we went for surgery. We did varus osteotomy and Pemberton acetabular procedure here. So she was doing little better with this hip surgery. So what will be the take-off message of today's lecture? CP is incurable. We cannot cure CP. That always I used to say to the patients we see. Early treatment, the outcome is better. and the early treatment should start with physiotherapy, occupational therapy, braces, everything. Surgery can't solve the problem fully. We can just improve the situation, improve the condition of the baby. Release should be done in a single sitting, what we call single even multi-level release. And post-operative physiotherapy and braces are very much essential. Without these braces and physiotherapy, there won't be a good result. And the patients who have patient selection is very much important, because in a quadriplegic, big surgeries are not helpful. In a quadriplegic patient, with all the surgeries, we may not be able to make the make the patient work. So in quadriplegics, maybe only hip salvage surgery is essential. So we have to know that which patient will be helped with surgery. So these are my take-home messages of today's lecture. Thank you for listening to me with. So should I stop share? We can stop share and go for questions and everything now.
Thank you, sir, for your nice, elaborate, and wonderful presentation with polling and question answers and pre-operative and post-operative outcome of these babies. And we should and we will be encouraged with your presentation to come more in pediatric orthopedics. Professor R. Kori, sir, please tell something and about the presentations, and should I go for question answer, please? Sir, unmute yourself, sir.
Ashfaq.
Yes, sir.
Go for the question and answer. This is cerebral palsy is not an easy subject, but he has presented very well, and Sarwar is doing CCP for many years now since his training. So let us go for the question answer session first, then we can discuss in each question. Ashfaq.
Yes, sir. Thank you, sir.
Go for the question and answer, finish the question and answering, then we can discuss about this in the period of question and answering, and after this question and answer session, we can discuss about among the seniors.
Yes, sir. So question and answer session is started now.
Yes.
First question from Medina, sir. Why diplegic CP has no low IQ? Sorry, Salam, sir.
So actually, when this is from the initial pathology, the diplegic, the upper, this is a cerebral disease. This is not a limb disease. When during the birth process or during the pregnancy, this happens, the patient, the diplegic who develop diplegic patient, their upper psychic functions are not that center. The higher psychic center is not involved in that process. That's why usually the diplegics do not show this low IQ. Hemiplegics usually have 30% low IQ. 30% hemiplegics have low IQ. And quadriplegics, most of the quadriplegic patients, they have low IQ. This is developmental. It happens developmentally.
Thank you, sir. Next question from Rafiq Nawaz Khan, sir. Does Botox is using in Bangladesh? And
oh yes, the video I showed, that is my video, and I am giving regularly Botox. I have given I don't know, around 50 patients I have Botox, but much more Botox is given by the neurophysicians, pediatric neurophysicians. One of the highest Botox user in the country is probably Professor Narayan Shah. Narayan Shah is a professor of neuromedicine in NIMS. He uses Botox very frequently. The neurophysicians use Botox. The cosmetic surgeons, the cosmetologists, I mean skin and skin specialists, they also use physiotherapy, Botox. I use it for CP patients.
Here's another question. Is it too much expensive? How is dosing schedule?
To the best of my knowledge, the Botox which is produced in America, in United States, which name is Botox, that is the cost is around 30,000 plus per vial, 100 unit vial. And one South Korean one is some 24,000 vial, that is probably named Neuronox, and one Chinese version is 18,000 per vial. And what was the next question?
How is dosing schedule?
Or dosing schedule? Yeah, there is no such dosing schedule. Usually it is said, in if you go through the literature in the Botox, they say the effect usually lasts for 3 months. But what happens when we use Botox, we tell the patient, and after that we usually give plasters, and after that physiotherapy. So the combined effect at least lasts for 1 year. So if you use Botox once, the next Botox dose may be deferred to 1 year after the medical effect. The effect of the medicine remains for around 3 months.
Next question from Dr. Alok sir. Except referring to Territory Hospital, is there any treatment can we provide for cerebral palsy patients at district level?
Sure, of course. Physiotherapy should be the first thing to be started. Press is the next thing you can use. And serial casting is one thing that you can do anywhere. But during serial casting, you have to remember one thing, that the bony prominence has to be protected properly, the knee, ankle, and these areas. So you can very well do it. And surgeries, these surgeries actually are being done in many places in Bangladesh. I should say in Bogura, Taposh is doing probably, Badul is doing in Kumilla. Apart from Dhaka, in Chittagong, some people are doing. So CP surgeries are done in many places.
Regarding Botox, another question came from Dr. Muhammad Mushfiqur Rahman sir. How Botox act? Mechanism of action he mentioned.
It acts in the motor end plate. It prevents the neurotransmitter that does this contractile phase, contracting. So it works in that motor end plate.
Next question from Lieutenant Colonel Abdul Qadir sir. He is from Central Africa. Thank you, sir, for questioning here. His first question is role of MRI for diagnosis of CP. Role of MRI for diagnosis.
No direct, no direct role in diagnosing CP with this MRI. You can just exclude other things. Patient having CP may well have a normal MRI. So we do not do MRI for a CP patient. We diagnose the cerebral palsy from the history and the clinical examination. But if you have any suspicion that the patient might have some other things, you might go for MRI of brain. But let us remember, with MRI, even with CP patient, the patient might have completely normal MRI.
Kader sir, having another question, mechanism of action of Botox you have mentioned earlier, and how to apply Botox.
So I was showing it. I do it manually. Some people do it with ultrasonogram guidance. MRI Botox uses much more to the point. It happens much more to the point. What we do, the video, if you have seen that, when we select which muscle we have to give. Say, I was showing the video of the hip adductors. So we take the patient with the hip adductors exposed, or say hamstring, whichever exposed, and we do not give this Botox to the either end of the muscle, but because the motor end plate remains more in the middle to distal part. So we put needle and move that particular muscle and see if those needles are moving. If one of those needle doesn't move, we understand that that needle hasn't gone to that particular muscle. So for an adductor, we'll adduct and abduct the hip. If the needles move, then we give that Botox there. So Botox is given in multiple places, multiple areas. 100 unit of Botox is if you see the Botox vial, there is no medicine seen inside, only some powders, and that is attached to the lower end of the bottle. And we use normal saline. Normal saline suspends the medicine, and we use with the syringe, give it with the syringe.
Dr. Asad says,
Next question.
How long does Botox last in cerebral palsy? And is Botox safe for long term? Question by Dr. Asad.
Botox is very safe, has been proved to be very safe drug. I have seen there is only one history in America of a patient dying from Botox. Otherwise, Botox, and they were not sure that the patient died from Botox. The patient died after Botox. So otherwise, the Botox is very safe. And that how long I have said only that 3 months. It is the effect of the medicine lasts for only 3 months, around 3 months. But if we go for physiotherapy and use of braces, the combined effect will last for about an year.
So next question, Dr. Nipen Kundu. Single level, multi-level procedure followed by maintenance plaster can be done at district level? Asked by Dr. Nipen Kundu.
Of course.
Yes.
Of course, Nipen Kundu. You have worked with me, and you have seen this. And we have shown that the surgeries are very simple. We just have to examine the patient properly and decide which patient needs surgery and what are the surgery. Actually, the decision is crucial. The decision is very crucial, but surgeries are very simple. But I told already, many people in around Bangladesh are doing CP surgeries. So this very well can be done in the district level.
Thank you, sir. Next question from Dr. Jakir. What are the treatment protocol of apparent equinus of a soleal tightness?
So apparent equinus will not go for apparent equinus. You know, that is no equinus. Apparently, it looks like equinus. So we will not touch that gastrosolius with apparent equinus. If there is soleal tightness, how much tightness, that can be controlled with physiotherapy. That can be controlled with physiotherapy and Botox and plaster or surgery, that we will have to decide. And if there is tightness, we go for those procedures. I have said that gastrosolius tightness is done by tendo-Achilles lengthening, by Beckett's procedure, by jetplasty, by Strauss procedure, Vulpius procedure. Many procedures are there.
Next question, Lieutenant Colonel Abdul Qadir sir. After soft tissue release in cerebral palsy, how many days we keep the plaster, and when we allow the patient to walk?
3 to 4 weeks we keep the plaster, and after that we let the patient to walk. If no bony procedure is done, 3 to 4 weeks we keep the plaster, then the patient can walk.
Mohammed Rafiq Nawaz Khan sir. Postoperative video should be out of shoes and above knee exposure. Oh, he has a comment that postoperative video should be out of shoes and above knee exposure. And another question he asked, what is the ideal age to start ideal treatment by orthopedic surgeon? Ideal age to start ideal treatment.
I'll comment about the first comment. Actually, the CP patient needs these braces or exercises may need till the age of 18, 19 years. So we keep these braces for quite a long time. I said once that the post-operative management with physiotherapy and these braces are very essential. So patient also works without the braces, but most of the time, who is having the ankle release, he might need to use that brace for very long time. The ideal is to start ideal treatment by orthopedic surgeons. The multi-level, single, even multi-level release is done around the age of 7, 6 to 8 or 9. That is the best time. And the orthopedic surgeon's role is there. But one thing we must remember, if there is hip at risk, the hip is dislocating or subluxating at the age of 3, we might have to intervene as an orthopedic surgeon at that age of 3. Except for salvaging the hip, we usually do not go for surgery before the age of 7, the orthopedic surgeon.
Thank you, sir. Next question from Dr. Tafim Kabir. Where possible, does bone procedure is better than soft tissue procedure? Where possible,
Please, tell it again.
where possible, does bone procedure
Yeah.
is better than soft tissue procedure?
Yeah. When possible, actually the older children need these bony procedures. The younger patient doesn't need these bony procedures. So when possible, the bony procedure is better to do without releasing the soft tissues, because without doing the soft tissue procedures, we weaken the muscles. It is better to do bony procedures when possible. You are right, Tafim.
Next question from Dr. Ashik Ahmed. How hypotonic CP develop?
Well, these are all developmental. CP happens during, before, or after the birth process, and it happens during that. Which area of brain has been involved? If the speech area of Broca is involved, the patient will not be able to speak properly. This way, and these hypotonics are only 1% of the cases, and the spastic, I said 65%. This is during the developmental procedure. When the brain insult is done, then only happens this.
Thank you, sir. Next question from Lieutenant Colonel Abdul Qadir, sir. When I go for surgical procedure in CP patient?
CP patient, I
Already discussed.
Already
discussed that
about
discussed.
at 3 years, hip anytime, at any age hip, but usually around 7 is for all others.
Okay. From Dr. Abujar Muhammad Salimullah, he said, very nice presentation, examination and operation about lower limbs, but missing about upper limbs. Will it need separate
Salim
session?
bhai, very important thing you have raised. Actually, we usually do low limb surgeries. I have done few upper limb surgeries, and I forgot to put this here because maybe only 1 to 2% needs patient needs this upper limb surgeries, and upper limb surgeries are not done much, but we have done this long flexor release. Then we have done this rerouting of pronator teres. The hemiplegics usually have this pronation of upper limb like this. Usually the pronator teres is tight. We remove the distal portion of the pronator teres in a jet style, put it through the interosseous membrane and bring it on the other side and attach it with the other side. Sorry, I didn't because I had to shorten this lecture so much. I could not do that. We do rarely, but we do some upper limb cases.
Thank you, sir.
Sometime next.
Dr. Mehdi Nawaz, sir, another question. Do you use muscle stimulator to give Botox?
No.
No, already I got the answer.
Yeah.
But Rumal bhai, my another question is like with this, in one muscle, that is if you give Botox, how much Botox do you give for one muscle?
Well, that I should have also added here. Let me know about that. A patient should not receive 8 to 10 unit per kg, more than 8 to 10 per kg body weight of Botox in a single event. Let's say one patient, the weight is 20 kgs. So if we give 10 units, that means 200 units or 2 vial highest we can give to that patient. And if you ask about the single muscle, the dose is like that. Think about gastrosolias.
Yes.
When you give in gastrosolias, this is 3 units per muscle per limb per kg body weight. So one patient we are giving it in gastrosolias, the weight is 20 kgs. That limb will need 3 into 20, that means 60 unit of Botox in gastrosolias. It is for biceps, it is 2, for gracilis, it is 1, for medial hamstring, it is 2, for pronator teres, it is 1 unit per kg body weight per limb. This way, this is distributed. I should have again used that. Actually, I had to shorten so much.
Thank you, sir. Professor Kristopio sir have been compliment excellent presentation, and his question was how much dose is needed for a single muscle and duration of effect. That has been answered already.
That is the answer.
Professor Moniruddin Sarkar sir having a question. Any adverse effect to or contraindication of injection Botox?
I have seen the literature. They have said though no contraindication so far for injection Botox, and they haven't seen any adverse effect. I don't know if anything else.
Another question regarding Botox from Dr. Johul Islam. Does Botox is alternate of soft tissue surgery?
No.
May not be, because Botox is used in cases of the patients during the age of 4, 5, 3, 4, 5, 6, 7. And after the age of 7, when it is needed, soft tissue surgeries will be more helpful. But of course, Botox will help this release of some spasticity. So, to some extent, that can be done.
Thank you, sir. Next question from Dr. Shamu, sir. How do you correlate GMFCS regarding to tendon release surgery?
We have seen GMFCS 1, 2, 3, 4, 5. Actually, for assessing a patient, we do not use this GMFCS, rather we use FMS, the Functional Mobility Assessment Scale. So before, and that is done by letting a patient walk in 50, 100 and 500 meters. And that is done before surgery and after surgery. So if we need to assess the patient with the interventions we have done, we usually use this Functional Mobility Assessment Scale, not this GMFCS scale. GMFCS is more used by the physiotherapist, physiatrist, and that gives us a idea about the condition of the patient.
So next question from Muhammad Rafiq Khan, sir. Is there any age limitation in pediatric ortho to use Botox?
I don't know whether there is age limit of Botox, probably not. But doesn't need below the age of 3, 4, it's not usually needed.
Thank you, sir. Next question from Ghulam Farooq, sir. Has there any personal study about effect of use of Botox and surgery?
Sir, no, I don't have my personal comparative study. I have given Botox to about, I don't know, 40, 50 patients, and I have done surgery more than 500 patients. And the problem I see using Botox in Bangladesh, because 1 vial or 2 vial of Botox is the amount of cost of a surgery almost. So it is very rarely the patient they go for this Botox. So I don't have any comparative study personally on Botox and surgery, sir.
Thank you, sir. From Dr. Shamu, sir, how can we help a non-spastic type of CP?
I mean, the hypotonic CP, braces, exercises, I mean, physiotherapies, occupational therapies that can help with this hypotonic CP patients, sir.
Professor Kristopio, sir, having another question. Which one is better, either Volpias? Professor Kristopio, sir, having another question. Which one is better, either Volpias or Becker's procedure for earthiness correction in your experience?
Well, Becker's procedure I used to do very commonly because my mentor, Professor Ashok Johari, used to do this Becker's procedure. Right. I learned this Volpias procedure from Professor Koiri sir. I didn't use that much, but when I went to Korea, I again saw that Professor Bobby's mentor, Professor Hugh, he uses this Volpias procedure. So I usually do this Valpias procedure, which I learned from my first mentor, Professor Koiri sir, and I do Valpias now. Actually, we cannot say which is better or not. The stress procedure, which I have done few, that is much more selective stress procedure. But rather than this jet plus T, this Valpias, Baker stress, these things are better, I think.
Thank you, sir. Kori sir, do you want to add something?
Yes, about these Volpias and Bakers, the procedures, both the procedures works. There is not much different, but elongation of the tendo Achilles.
Yes,
As many of the surgeons do this, this is not a good procedure because this causes much weakness of the muscle. So muscle release is better than elongation of the tendo Achilles. And one thing I want to add that we have seen that some of the periphery doctors, they do tendo Achilles release before even 3-4 years of age for the equinus. For the equinus. But this is the teaching of at least today's teaching. You can, from this lecture of Professor Rumel, you should learn that in the case of cerebral palsy, no operation should be done before at least 6 years of age, 6-7 years of age. Before that, you should go for the physiotherapy or Botox injection, bracing, etc. One thing I want to add, because not only these muscles, a patient or child will not obey your command before 6 years of age. But you have released done the Volpias and corrected the equinus, and after that, in a case of 4 years of age, the child will again walk with the equinus, and there will be recurrence of the deformity, and it will be more difficult to do in the next stage. So don't do any release before 6 years of age, 7 years of age, especially the correction of the equinus. This should not be done. And Volpias and Bakers, I have done both works, but your maintenance of this correction of deformity is much more important. In one problem we face is good physiotherapist, because Rumel has developed a team of physiotherapists, because physiotherapy has got a very great role in treating cerebral palsy patients. So we treat many of the difficult cases. Now I send the patient to Rumel because he has got the team. I don't have that good physiotherapist with me, and I don't have time also, because I see the children as well as I see the hand surgery patients. And regarding the hand surgery in cerebral palsy, we have done hand surgery correction of the deformities in upper limb, and Krishna probably has asked about the hand surgery in cerebral palsy. We can go for this pronator rerouting of the pronator teres. We can even go for the tendon transfer of the flexor carpi ulnaris to the extensor to correct the flexion deformity of the wrist and hand. These things can be done, but these all operations are after 7, 8 years of age, not before 7 years. Any other questions?
Yes, sir. From Ghulam Farooq sir to Professor Kori sir. Sir, in congenital deformity for functioning of the part, multidisciplinary approach is required. Do you think about this, sir?
And congenital?
In congenital deformity for functioning of the part, multidisciplinary approach is required. Do you think about it, sir?
Yes, multidisciplinary team is required, approach is required.
No, sir, my question to you, usually we need so multidisciplinary approach, but in our country, no center is developed still now. whether you have thinking about this, as you are the pioneer in the congenital deformity correction in
Oh,
Bangladesh.
acha. This is your suggestion because we could do this here. Everybody now should try to develop now this multidisciplinary. You must have physiotherapist with you who is dedicated to these children in pediatrics, orthopedics, especially the deformity correction, cerebral palsy, etc. Then in cerebral palsy, especially physiotherapy, occupational therapy are needed, you know. But Farooq, you know that we don't have that good physiotherapist. Unfortunately, I tried to develop one boy, Anwar, you know, Babu, and he died about 3-4 months back due to COVID-19 and cardiac problem. He was a very good boy in Nitor, you know, probably all of you know him. Babu, his nickname was Babu, Daknam. Is Anwarul Islam. He was with us for many years and he learned many of these hand surgery in pediatrics, orthopedics. He was helping us. But we have to develop. Physiotherapy is a very important part in hand surgery as well as in pediatrics, orthopedics, especially in case of CP management. Very important, CP and congenital deformities. Next question.
Yes, sir. Next question from Dr. Taufik. Regarding FMS or GMFCS, do they have any role in regards to treatment, decision making, or just prognostic value?
This FMS, the Functional Mobility Assessment Scale, that has got the role in prognostic value, and GMFCS is just primary assessment.
Next
For
question.
prognosis, we use FMS.
Next question from Munjaman Shine, sir. Though there is spasticity, basically weak muscle, here MRC grading is possible or not?
Well, important thing, Professor Munjaman Shaheen, actually this should be clear to everyone that though these are spastic, these are weak muscles, and we should check each and every muscle we are going to do surgery on that. And if the MRC grading is below 3, it is better not to do surgery in that particular muscle, because after 3, you are doing the surgery MRC 3, and that will become 2, and that will rather deteriorate the patient. So either start with physiotherapy, strengthen the muscle, or if it doesn't, that will not help. That's why the quadriplesics are not done surgery. So MRC grading is very much important to assess whether we should go for surgery that particular muscle or not.
Sahin, I want to add, it is possible, but it is a bit difficult. The MRC grading, in case of a nerve injury, you can assess the muscle very easily. MRC grading, when cerebral palsy, it is difficult, especially difficult in very small children. That's why we say that not before 6-7 years of age. When the child will not obey your command, you cannot grade the muscle, you know. So that's why the operations are delayed. You must remember that the 6-7 years of age, then you can ask the child to hold the muscle, to contract, then you can grade it. Otherwise, in case of 2-3 years of age, you cannot grade the muscle. But MRC grading is possible in case of cerebral palsy.
Thank you,
but
sir.
it is
Thank you,
difficult.
sir. Great learnings. So thank you, sir. Great learning from you, sir. Thank you, sir.
Last question from Dr. Taufik. What scale or scoring system do you use to measure pre-op or post-operative findings, outcome measurement?
I've just said the FMS, the Functional Mobility Assessment Scale, that helps in prognosis after doing any procedure, plaster or surgery, whatever. The FMS grading is used for surgical outcome measures.
So, no question is left now. Sir, respected teacher, Professor Ayarkoi sir, this is now the open session. You can mute yourself to share your Any
comment
questions
or
any comments?
experience or
Experiences.
comment or experience.
Yes,
স্যার আমার একটা ছোট্ট কমেন্ট ছিল স্যার অথবা
হ্যাঁ হ্যাঁ বলো
স্যার স্যার
যাই
ওই
হোক।
ইকুইনাসটা স্যার অনেক সময় দেখা যায় শুধু একটা লিম তার সাথে ইকুইনাস আছে, তো এটা কোনো সময় স্যার ওই যে ওপেন অর ক্লোজ পারকিউটনেস ফ্র্যাকশনাল লেংথেনিং একটা কথা আছে কিনা স্যার? এরকম আমরা করে দেখছি স্যার, খারাপ না, এখন আমি জানি না এই
না না
ব্যাপারে
এটা হইলো এক্সপিরিয়েন্স হইলো জাহিদ।
স্যার
আমরা তো বহু বছর থেকে করি, অনেক সময় না
জি, জি,
জানিয়েও করছি আগে।
জি,
তো
জি,
এখন
স্যার,
আমি
জি,
বলি
জি, স্যার।
শোনো যে এই ইকুইনাস যদি থাকে ফ্র্যাকশনাল লেংথেনিং করলে একটু উইক হবে মাসল, আর সেরিব্রাল পালসিতে তো উইক থাকেই। কাজেই 6-7 বছর যাওয়ার পরে যদি করো, এর আগে
স্যার
তোমাকে
পরে, হ্যাঁ।
স্ট্রেচিং করে ফিজিওথেরাপি করে প্যারেন্টসদের বুঝায় রাখবা যে যতটুকু সম্ভব স্ট্রেচ করা, প্যাসিভ স্ট্রেচিং করা, ব্রেসিং করা। তারপরে 6-7 বছর বয়সের সময় করলে তোমার
স্যার।
রিকারেন্সটা খুবই কম হয় এবং ওটা থাকে, ভালো থাকে। এবং
এটাও বোধহয় একটা ভালো টেকনিক কিনা স্যার, সেটুকু বলতে চাচ্ছি।
হ্যাঁ সেটা করা যাইতে পারে, কিন্তু 6-7 বছর পরে। আর
সেটাই।
প্রবলেমটা যেটা হইলো যে আমাদের সেরিব্রাল পলসিতে টেন্ডোঅ্যাকিলিস আমরা শর্ট যেটা করি, যে মনে করো আগে যেটা পোলিওতে করতাম, যে শর্ট টেন্ডোঅ্যাকিলিস আছে বা ইন কেস অফ তোমার ক্লাব ফুট, নেগলেক্টেড ক্লাব ফুট
টেনোটমি না কিন্তু স্যার।
রাখো, হ্যাঁ আমি বুঝতে পারছি।
জি, জি।
হ্যাঁ ওই পারকিউটেনিয়াস তোমার স্টেপ রিলিজ উপরে
yeah,
নিচে দিয়ে, তাও টেন্ডনের মধ্যে করার চেয়ে মাসেলে করা সেফ, কারণ টেন্ডনের লেন্থ তো বাড়াইলে আমাদের মাসেলটা শর্ট থেকে যাচ্ছে। সুতরাং সেরিব্রাল পলসিতে মাসেলের ফাইবার গ্যাস্ট্রোকনিমিয়াস না সলিয়াস ইনভলভ, সেটা ডিটেক্ট করে তোমার মাসেলে রিলিজ করলে সুবিধা। সেই জন্য ভলপিয়াস এবং ব্যাকপ্যাসের রেজাল্ট ভালো, টেন্ডোঅ্যাকিলিসটা ইনট্যাক্ট থাকলো, সেটার রেজাল্ট ভালো আর কি। আর যেন আর
আমি একটু পয়েন্ট বলি।
হ্যাঁ আর বলো রুমেল।
স্যার ওই যে জাহিদ ভাই যেটা বলছেন, একটা প্রসিডিউর হোয়াইট স্লাইড সার্জারি ইজ অলসো ডান জাহিদ ভাই, দ্যাট উই ডু এন্ড দ্যাট ইজ গুড, বাট দ্যাট এই যে স্যার যেটা বললেন যে অ্যাসেসমেন্ট ইজ এসেনশিয়াল, অ্যাসেসমেন্ট না করে এগুলো করলে অনেক সময় ডিজাস্টার।
অনেক সময় আমরা এমনও দেখছি যে হ্যামস্ট্রিং টাইট আছে, টেন্ডোঅ্যাকিলিস লেংথেনিং করে দিছে, তখন আগে যেরকম হাঁটতো তার চেয়ে আরো খারাপ হাঁটে, বুঝছো না? তো সেটা চিন্তা করতে হবে সেরিব্রাল পলসিতে, যে হ্যামস্ট্রিং এর জন্য ইকুইনাস করে হাঁটে, এখন হ্যামস্ট্রিং রিলিজ না করে টেন্ডোঅ্যাকিলিস রিলিজ করে দেওয়া হয়েছে, তো দেখা গেল যে আরো খারাপ হাঁটতেছে। তো সেই কারণে ওই যে ওয়ান স্টেজ যেটা রিলিজ, অল মাসলস ওয়ান স্টেজ অপারেশন, হ্যাঁ সেইটা এখন খুবই হেল্পফুল, যে এক পা করলা আর এক পা পরে করলা, তার চেয়ে সবগুলো একসাথে করে দিতে পারলে তারপর রিহ্যাবিলিটেশন ইজি ডেফিনেটলি, এবং ইট ইজ ভেরি হেল্পফুল। আর আরেকটা জিনিস যেটা আমি সেরিব্রাল পলসিতে চিন্তা করি, সেটা হলো যে রুমেলকে জিজ্ঞেস করবো যে তোমার বোটক্স দেওয়ার সময়ও কি মনে করতেছো যে সমস্ত মাসল স্পাস্টিক আছে সবগুলারে একসাথে দেওয়া উচিত?
স্যার সিপি পেশেন্টে তো সবারই মানে প্রায় সব মাসলই স্যার স্প্যাস্টিক থাকে, যেগুলো স্যার খুব বেশি সমস্যা করে, যেগুলো কমনলি এফেক্টেড হয় সেগুলোতে আমরা দেই স্যার বেশি। এখন তো ওর আমি
যেমন আমি বলছি যে অপারেশনে যেরকম চিন্তা করতেছি আমরা, যে সিঙ্গেল স্টেজ, মাল্টিপল অপারেশনে ওয়ান স্টেজ, হ্যাঁ তো ঠিক সেরকমই কি সিঙ্গেল সিটিং এই সবগুলোতে বটম
দিলে ভালো হয় স্যার?
আচ্ছা
জি স্যার,
তাহলে অনেক টাকার ইনভলভমেন্ট
দিলে ভালো হয় স্যার,
আমি অবশ্য
সমস্যার জন্য বাংলাদেশে দেওয়া যায় না স্যার।
হ্যাঁ যেমন এখন যদি দুই ভাই লাগে
প্রচুর দেয় বোটক্স, জোহরি স্যার প্রচুর দেন,
এখন যদি দুই ভাই লাগে তাহলে তো তার 60-70 হাজার 80 হাজার
সার্জারির কস্ট লেগে যাবে,
সার্জারির কস্ট হয়ে যায়,
সার্জারির কস্ট সেটাই
বলবো স্যার, বলবো স্যার।
তারপরে যদি বলো যে রোগীকে যে 3-4 মাস পরে এটার অ্যাকশন নাও থাকতে পারে, তাহলে তো রোগীদের রাজি করানো মুশকিল। তারপরে যাই হোক, কে জানি বলতে
স্যার বলবো।
হ্যাঁ
স্যার স্যার দীপঙ্কর স্যার, ওই I have been trained for Botox in 2011 from Xi'an University. চায় না।
জানি
বোটক্সের উপর আমার ট্রেনিং আছে স্যার। বোটক্সে নরমালি এখন যেটা বাচ্চাদের জন্য যেটা আপনি বলতেছিলেন, বাচ্চাদের জন্য স্যার 4 ইন্টারন্যাশনাল ইউনিট পার কেজি বডি ওয়েট ইউজুয়ালি। হাইট দেওয়া যায় 6। It can be repeated after 6 to 9 months, but repeated injection causes the immunity, মানে ওই হাইপার সেনসিটিভিটি রিঅ্যাকশন হয় এবং ওই ক্রস অ্যান্টিবডি তৈরি হয় স্যার, যার জন্য ইফিকেসি কম। আর যেটা বললেন যে সবগুলো মাসলে মাল্টি লেভেল দেওয়া, এটার একটা লিমিট আছে, এর উপরে দেওয়া যাবে না স্যার সিঙ্গেল স্টেজে। যেমন স্যার গ্যাস্ট্রোকনিমিয়াসে হাইট দেওয়া যাইতে পারে 60 IU। এটা স্যার আমার ট্রেনিং আছে স্যার। এবং হ্যাঁ 60 IU সবচেয়ে ভালো হয়। রুমেল যেটা বললো, রুমেল যদি ওই ইলেকট্রিক্যাল স্টিমুলেটর ব্যবহার করেন স্যার, মিনিমাম স্টিমুলেশনে ম্যাক্সিমাম কন্ট্রাকশন যেটা হবে, বাট নেভার ইন্ট্রোডিউস, এটা দিতে হবে 2 to 3 সেন্টিমিটার এরিয়া জুড়ে। এটা একটা বই আছে আমার কাছে ছিল, এখন তো আমি 17টা করার পর আর বন্ধ করে দিয়েছি আমি ব্যস্ততার কারণে। এটা আমার আসলে সরি।
আচ্ছা
হ্যাঁ, এটা ওই সবখানে সব জায়গায় দেওয়া যাবে না স্যার, সবগুলোতে একসাথে দেওয়া যাবে না স্যার। এটা আপার লিমিট আছে,
মানে ডোজের লিমিট আছে আর কি।
ডোজের লিমিট আছে স্যার। আপনি স্যার 100-200 ইউনিট দিলে রিঅ্যাকশন হবে স্যার, টক্সিসিটি ডেভেলপ করবে। আর ওই যে রুমেলকে বললাম একটা কোশ্চেন ছিল যে কোথায় কাজ করে, এটা মডারেট প্লেটে, বাট ইট অ্যাক্টস এজ এ কম্পিটিটিভ ইনহিবিটর টু দা ওই অ্যাসিটাইলকোলাইন রিসেপ্টরস। প্রি-সিনাপটিক ভেসিকুলে কাজ করবে, ইট ইনহিবিটস দ্য রিলিজ অফ অ্যাসিটাইলকোলাইন। এটা স্যার সিনাপটিক ক্লেফটে ঢুকতে রিলিজ হইতে দেয় না। এইটা
ওইটাই তো মডারেট প্লেট।
ঠিক আছে ঠিক আছে,
ওইটাই মডারেট।
ঠিক আছে।
হ্যাঁ, থ্যাংক ইউ দীপঙ্কর ফর দি কমেন্ট। আমার মনে হয় যে 10টা বাজে, আমরা আর মোটামুটি সেরিব্রাল পালসি দেখলাম। কাবি কিছু বলবেন?
আমি ছোট্ট একটা অ্যাড করব ফর আওয়ার ইয়াঙ্গার ডক্টরস।
আপনাদের যার চলে প্লিজ এটা একটু বন্ধ করেন অথবা নিজেকে মিউট করেন।
হ্যাঁ,
সেটা হচ্ছে যে when young patient come to you, 3 বছর 4 বছর 5 বছর মারা নিয়ে আসবে, তখন আপনার একটা ডিসিশন নেওয়ার দরকার আছে যে this child is going to be a walker or a non-walker. হ্যাঁ, মানে এই বাচ্চাটা 4 বছর বয়সের বাচ্চাটা কি এখন ভবিষ্যতে সে হাঁটতে পারবে কি পারবে না, এগুলোর জন্য কিছু মাইলস্টোন আছে। যে বাচ্চা 2 বছর বয়সে যদি ইন্ডিপেন্ডেন্টলি না বসতে পারে, সম্ভবত সে নন ওয়াকার থাকবে। যে বাচ্চা 4 বছর বয়সে ইন্ডিপেন্ডেন্টলি দাঁড়াতে পারবে না, সে পসিবলি নন ওয়াকার হবে। এই ডিফারেন্সিয়েশনটা করার দরকার আছে এর জন্যে যে আপনি কি ধরনের ট্রিটমেন্ট দিবেন। ওয়াকারের যারা ওয়াকার হবে তাদের জন্য এক ধরনের ট্রিটমেন্ট হবে, যারা নন ওয়াকার হবে তাদের জন্য একটু অন্য ধরনের ট্রিটমেন্ট হবে। তো এটা আগে থেকে আপনাকে এটা ক্যাটাগরাইজ করে ফেলতে হবে। স্যার কিছু অ্যাড করবেন কিনা?
না ঠিক আছে, এটা একটা কথা আছে সেরিব্রাল পলসিতে টেক্সট বুকে যে the child who cannot walk within 6 years
by 7 years
will never walk probably. হ্যাঁ, তো সেটা আমরা যারা এখন সেরিব্রাল পলসি করে তারা কিন্তু আবার একটু টাইমটা এক্সটেন্ডও করতে চায়, যে তারা অ্যাসেস করে তাদের অপারেশন করে স্টেবিলাইজেশন করে কিছুটা মোবিলিটি যদি দেওয়া যায়, যে হুইল চেয়ার বাউন্ড পেশেন্টকে যদি তুমি ক্রাচে নিতে পারো তাহলেও লাভ। কিন্তু সেগুলা করতে গেলে ডেডিকেটেড ডিপার্টমেন্ট লাগবে অথবা সেটিং লাগবে যেখানে ফিজিওথেরাপি ভালো লাগবে। তো ডেফিনেটলি কাবির ওই পয়েন্টটা ঠিক আছে যে ইউ মাস্ট অ্যাসেস, যেটা হুইল চেয়ারে চলবে সেটার সব তুমি টেন্ডন রিলিজ করলে তাতে তো লাভ নাই। তাকে যদি হাঁটতে পারে তখন না তোমার, ওই জন্যই যে ইনিশিয়াল এই স্টেজিং খুব ইম্পর্টেন্ট যে সেরিব্রাল পলসিতে। রুমেল কিছু অ্যাড করবা?
জি স্যার, আপনি যেটা বলছেন 7 বছরে যে না হাঁটবে সে আর কোনোদিন হাঁটবে না, ইউজুয়ালি সেটা হচ্ছে কোয়াড্রিপ্লেজিক পেশেন্ট।
হ্যাঁ,
এবং এই কোয়াড্রিপ্লেজিক পেশেন্টদের অপারেশন করার আগে আমরা 10 বার ভাববো। আমরা তাদের অপারেশনটা করবো কি, হয়তো সে আরেকটু কেমন ভালো করে হুইল চেয়ারটা ব্যবহার করতে পারে, সে যেন হিপ ডিসলোকেশন না হয়ে যায়, এই ক্ষেত্রে আমরা তাদেরকে
সেই জন্য আমি আমার মনে আছে একটা, আমি এক রোগীর 25 বছর বয়সে অপারেশন করছি। হ্যাঁ, তো সেইটা এক মহিলা হুইল চেয়ারে চলে, শিক্ষিত মহিলা, হুইল চেয়ারে চলে, সে টিচিং এ থাকা খ্রিস্টান ভদ্র মহিলা, টিচার, হুইল চেয়ারে করে, সে টিচারে, কিন্তু তার 25 বছর বয়সে সে আমার কাছে আসলো যে তার দুই হিপ অ্যাডাক্টর এত বেশি টাইট যে সে বলে যে তার টয়লেট করতে অসুবিধা হয়। Then I had to do this abduction osteotomy of both the hip, and she was fine for many years. I think as far as my follow up 10 বছর 12 বছর পর্যন্ত she was so happy যে she could abduct the both hip. এটা অ্যাডাকশন হইতে হইতে তার আলসার হয়ে গেছিল পেরিনিয়ামে, তো সেটা নেগলেক্টেড কেস আর কি। তো সেই জন্য অনেক বড় বয়সে অপারেশন করা লাগে অনেক সময়। সামটাইম এই ছোট অপারেশন তাকে অস্টিওটমি করে অ্যাবডাকশন করে দেওয়ায় সি ওয়াজ হ্যাপি যে তার সে টয়লেট ইউজ করতে পারে ভালো। তো সেই জন্য হুইল চেয়ারের পেশেন্টেরও যদি হিপ ডিসলোকেশন হয় তাহলে ইট বিকামস পেইনফুল অ্যান্ড ডিফিকাল্টি ইন ইউজিং হুইল চেয়ার। তখন ওই সেই জন্য সেইগুলোকেও করতে হয় মাঝে মাঝে
প্যালিয়েটিভ অপারেশন।
হ্যাঁ, মেহেদি কিছু বলবা?
বললাম স্যার, সেই সাথে অ্যাডাক্টর টেনোটমি করে দেননি স্যার?
হ্যাঁ, অ্যাডাক্টর টেনোটমি করার পরে ওটা তো একদম বনি ডিফর্মিটি হয়ে গেছিল।
ও আচ্ছা,
24 বছর 25 বছরে, বুঝছো না? তো জয়েন্টে ডিফর্মিটি হয়ে এটা অ্যাডাকশন মাসল রিলিজ করে হয় নাই। তা তো করছি, দুই পাশে দুই সিটিং এ আমি অ্যাডাক্টর টেনোটমি করে তারপর বনি প্রসিজিওর করে অ্যাবডাকশন অস্টিওটমি করতে হয়েছে, এন্ড ইট ওয়াজ ফাইন। সো আমার মনে হয় যে 10টা বাজে, আর কেউ কিছু বলবেন? আর আরেকজন প্রশ্ন করছিল, অলোক, মনে হয় চলে গেছে। অলোক বলছিল যে বাইরে পেরিফেরিতে করা সম্ভব কিনা। আমার মনে হয় যে সম্ভব। সব কেস তো সেন্টারে করতে পারবে না, একজনেই করতে পারবে না, কাজে পেরিফেরিতে আমরা অবশ্যই ভালো করে অ্যাসেস করে তারপরে করবে না কেন, পেরিফেরিতে করা সম্ভব।
ইন দ্যাট কেস হয়তো সার্জন নিজেই ফিজিওথেরাপিস্ট হতে হবে আর কি।
হ্যাঁ, তাকে না, এবং প্যারেন্টসদের শিখাইতে হবে অনেক বেশি।
আমি একটু জুনিয়রদের জন্য একটা কথা বলতে চাই, সেটা হচ্ছে সেরিব্রাল পালসি বুঝতে গেলে এখন আসলে যারা সিনিয়র আছেন তাদের জন্য একটু ডিফিকাল্টিস হচ্ছে। বিজি প্র্যাকটিশনাররা কখন সিপি ট্রিটমেন্ট করা ভেরি ডিফিকাল্ট, কারণ ইউ হ্যাভ টু গিভ দ্য টাইম টু মাস্ক দ্য পেশেন্ট। ওয়ান পেশেন্ট ক্যান কিল ইউ more than 40 to 5 minutes to 1 hour. You have to assess. It's very difficult. তো যারা জুনিয়র এখানে আছেন, আমার জুনিয়র কলিগস বা রেসিডেন্ট, তাদের বলবো যে আগে মাসেলের সবচেয়ে ইম্পর্টেন্ট জিনিস হচ্ছে মাসেলের ফাংশন বুঝতে হবে। প্রত্যেকটা মাসেলের আলাদা করে ফাংশন বোঝাটা খুব ইম্পর্টেন্ট, নট ফর সিনিয়র্স, সরি টু সে। আগে মাসেল কি ফাংশন করে, কোনটা কোন ফাংশন করে, কোথায়কার অ্যাটাচমেন্ট, অ্যানাটমি ইজ ভেরি ইম্পর্টেন্ট। যে আমার আসলে আমরা বলছি সেই মেমব্রেনস কোথায়, কোনটা কোনটা দিয়ে কোয়াড্রিসেপস কোনটা কোনটা দিয়ে, এবং তার অ্যাটাচমেন্ট কোথায়। এবং আমি মাল্টিস্টেজ সার্জারি করার ক্ষেত্রে ডেফিনেটলি আমি হঠাৎ করেই সিপি পেলাম, এবং সেই সাথে যদি ইয়ে পাই, কি বলে ওর নাম, ইকুইনাস পাই, আমি দেখলাম আর থেকে ভুলপিয়াস করি আর বেকার করি, এতে হঠাৎ করে করলেই আমি যদি সিম মেমব্রেনস না দেখি তাহলে কিন্তু বিপদ। এখন বিপদ তো মানে বড় ধরনের বিপদ হতে পারে, এবং এটা অ্যান্সার দেওয়া যাবে না। এই জন্য আমি বলি স্যার, আগে ইম্পর্টেন্ট হচ্ছে রেসিডেন্টদের জন্য মাসেল কোনটা কি ওয়ার্ক করছে সেটা আগে জানা, এবং সেইটা অ্যাসেস করে, এবং কতগুলো টেস্ট দেখানো হয়েছে। সেই রোমেল ভাই শুরুতে যে কথাগুলো বলেছিল, কতগুলো টেস্ট, ভেরি ইম্পর্টেন্ট থিং, যে সিলভার স্কোয়ার টেস্টটা ভালো করে জানতে হবে। এটা ফর গ্যাস্ট্রোসোলিয়াস, গ্যাস্ট্রিক পার্ট না সোলিয়াসের পার্ট, রেকটাস ফিউমারিসের পার্টটা কি হতে পারে। যদিও এখানে আরো অনেকগুলো মাসেল আছে, অ্যাডাক্টর রিলিজ বা অ্যাডাক্টরের পার্ট, সবটা যদি আমরা ভালো করে না জানি টেস্টগুলা, তাহলে হঠাৎ করেই কোনো এই কেসগুলো হাত না দেওয়াই বেটার। এবং কিন্তু বিষয়গুলো কিন্তু কঠিন কিছু না, বিষয়গুলো সহজ, শুধু একটু মাসেলের মুভমেন্ট, মাসেল ফাংশন এবং কোনটা কোথায় কিভাবে রিলিজ করা হয়, এই বিষয়গুলো একটু জানা দরকার। আমি একটু বলতে চাই ফর দ্য জুনিয়র্স।
ঠিক আছে মেহেদি, আমি বললাম আমার বইপত্র পড়তে হবে আবার। হ্যাঁ, সেরিব্রাল পলসি করতে গেলে সেরিব্রাল পলসি সম্বন্ধে পাবলিকেশন এখন তো তোমাদের জন্য খুব ইজি পাবলিকেশন পাওয়া, আমরা তো সেই কালে অনেক খুঁজতে হইতো আমাদের। যেখানে এখনো আমি করার সময় আবার বইপত্র দেখে নিয়ে করার চেষ্টা করি। হ্যাঁ, আর ওই রুমেল যেরকম করে তারা যে চার্ট রাখে চেম্বারের মধ্যে, চার্টের সাথে মিলায় দেখে, রেকর্ডিং, হ্যাঁ খুব ইম্পর্টেন্ট। যে তুমি একবারে ফার্স্ট এক ভিজিটে রেকর্ড করলা, পরের ভিজিটে আবার নিজের কাছে রাখা, অনেকেই তো আমাদের নাই এরকম রেকর্ডিং সিস্টেম। কাজে অ্যাটলিস্ট পেশেন্টের কাছে ভালো করে লিখে রাখো। আমি যেটা করি আর কি, যে যাই থাকুক পেশেন্টের কাছে প্রেসক্রিপশনে ভালো করে লিখে রাখি যে কোন মাসল কি গ্রেডিং বা কি করতে চাচ্ছি, প্ল্যান কি। আমাদের তো অনেকেই আজকাল প্রেসক্রিপশনের মধ্যে কিছুই লেখে না, ইভেন ডায়াগনোসিস পর্যন্ত লেখে না। সেইটা ঠিক না আর কি। জুনিয়রদের জন্য বলছি যে তোমরা, আমাদের তো লিটিগেশন প্রবলেম এখনো আসে নাই এরকম, এবং এটা আসতে আরো অনেক সময় লাগবে। আমাদের কোটি কোটি টাকার জিনিসপত্র বিক্রি হয়ে যাচ্ছে, সেটারই বিচার হচ্ছে না। আর তুমি লিখে রাখলা আর এটা অপারেশন কি করলা এটা দেখার লোক এখনো আসবে না। কাজেই তুমি তোমার ডায়াগনোসিস নিজের জন্যই, হোয়াট ইজ ইওর ডায়াগনোসিস, এবং তুমি কি চিকিৎসা করতেছো, কি তোমার স্টেজ কি ছিল, অপারেশন কি করতেছো, সেগুলো লিখে রাখো। তাইলে তোমার নিজের শিখা হবে, পেশেন্টের কাছে অন্তত পেশেন্ট নিয়ে আসবে। আর যদি নিজের রেকর্ডিং এ রাখা যায় সেটা তো বেস্ট। যদি এই সিস্টেম ডেভেলপ করতে পারো যে আমার কাছে সব রেকর্ড থাকবে, পেশেন্টের ফাইল নাম্বার থাকবে। কিন্তু প্রাইভেটে এটা ইজি না। এত ইনস্টিটিউশন যেমন রুমেলরা ডেভেলপ করতেছে সেটাতে ভালো হবে। আমাদের একটা সেট আপ আছে, আমরা মোটামুটি রাখি, কিন্তু সব জায়গায় তো প্রাইভেট প্র্যাকটিসে এটা সম্ভব না। অ্যাটলিস্ট ডকুমেন্টেশন খুব ভালো করে যতটুকু সম্ভব, যেটুক বুঝো এটুক লিখে রাখা দরকার। তারপরে তোমার 6 মাস পরে আসলে তুমি তোমার প্রেসক্রিপশন দেখেই বুঝবা যে কিছু নাই ওর মধ্যে, কি জন্য অপারেশন করছো তাই জানো না, তাহলে মুশকিল। আমার মনে হয় যে আজকে 10:15 বাজে। আমরা সবাইকে নেক্সট উইকে তো রুমেল বলবেই না, এটা আমার লেকচার আছে স্লিপ ক্যাপিটাল ফেমোরাল এপিফাইসিস। হ্যাঁ, তো ওইটা সম্বন্ধে আমি বলবো যে আমরা আশা করি তোমরা নেক্সট উইকে সবাই পার্টিসিপেট করবা। আর রুমেল বলো।
স্যার ওইটাই আগামী দিন স্যার আপনি হচ্ছেন স্পিকার, ক্লিপ ক্যাপিটাল ফেমোরাল এপিফাইসিস, মডারেটর হবো আমি, এন্ড আগামী দিনের চেয়ারম্যান হচ্ছে প্রফেসর মইনুদ্দিন আহমেদ চৌধুরী।
আর আশফাক ভালো মডারেট করছে।
থ্যাংক ইউ স্যার,
থ্যাংক ইউ আশফাক
ফর মি।
আর আই উইল থ্যাংক অল দি সিনিয়র্স যারা আছেন। হ্যাঁ, জাহিদ আমাদের সাথে থাকে, জাহিদকে অবশ্যই আমরা স্পেশাল থ্যাঙ্কস দিব।
ভালো লাগে স্যার আপনাদের অনেক জিনিস। আসলে স্যার মানে মেইন কথাটা ডায়াগনোসিসটা করা উচিত, এটাই আমাদের জুনিয়রদের সবচেয়ে বলা উচিত। চিকিৎসা তো ডায়াগনোসিস করতে পারলে চিকিৎসা বলাই আছে, তাই না স্যার? এইটাই হলো প্রবলেম।
So thank you all, thank you very much, thank you Rumel for your nice presentation. রুমেলকে তো আর আমি ধন্যবাদ দিই কি, রুমেল নিজেকেই ধন্যবাদ দেওয়া হয়।
থ্যাংক ইউ।
তবুও রুমেল ভালোই করছে, ভালো লেকচার দিচ্ছে। হ্যাঁ, থ্যাংক ইউ অল, থ্যাংক ইউ অলসো।
কাবি স্যার আসসালামু আলাইকুম। ভালো লাগলো স্যার আপনাকে অনেকদিন পর।
ভালো লাগলো, ইট ওয়াজ গুড
স্যার। থ্যাংক ইউ স্যার।
খুব ইন্টারেস্টিং টপিক আজকে।
হ্যাঁ, আসলে টপিকটা তো কঠিন স্যার, আসলে রুমেল তো খুব সুন্দর করে গোছায় বলছে, খালি শুনলাম আর কি।
তার কথাটা খুব ভালো লাগছে।
হ্যাঁ হ্যাঁ,
সার্জারি তেমন কিছু না, কিন্তু মেকিং
ডিসিশনটা মারাত্মক।
মেকিং ডিসিশন ইজ গুড। সব কথা শেষ হয়ে গেছে, তারপরেও অ্যাড করি,
স্যার বলেন।
যখন একটা জাম্পিং গেট পরে দেখি যে কাউজ গেটে হয়ে ফিরে এসছে, তখন কষ্ট লাগে। দ্যাটস ভেরি পেইনফুল। এখানেই হচ্ছে আমাদের এরকম যেন ভুল আমাদের না হয় আর কি। থ্যাংক ইউ এভরিবডি।
জাহিদ
স্যার, আসসালামু আলাইকুম।
ওয়ালাইকুম আসসালাম। শামসুদ্দিন স্যারের বিকালের অবস্থা কি জানেন?
শামসুদ্দিন স্যার বসে না স্যার, বসে না।
না বসে না, ভর্তি তো, গ্রিন লাইফে ভর্তি আজকে।
আজকের খবর জানি না তো স্যার। আল্লাহ,
গ্রিন লাইফে ভর্তি আছে অসুস্থতা।
আমি শুনি নাই স্যার, তাহলে আমি দেখি খোঁজ নেই স্যার একটু।
নজরুল ভাই কার কথা বললেন?
শামসুদ্দিন স্যার
স্যারের কথা না?
শামসুদ্দিন স্যার
শুনি নাই
ভর্তি।
স্যার।
হ্যাঁ ভর্তি। খুবই দুর্বল লাগতেছিল, কাল 2 দিন হলো স্যারের এই প্রবলেম নিয়ে ভর্তি হয়েছে।
মানে এমনি জেনারেল উইকনেস না স্যার?
জেনারেল
না,
উইকনেসের
COVID-টা
মতোই, আমি জানি না লাস্টে কি সিচুয়েশন।
আচ্ছা স্যার, খোঁজ নেই স্যার, দেখি।
ওই স্পাইনের কনফারেন্স, স্পাইনের একটা ছিল, ওয়েবিনার ছিল, ওটা বলছে তো।
স্যারের নাকি কোভিড পজিটিভ হয়েছে।
পজিটিভ হয়েছে?
হ্যাঁ, তাই তো লিখছে তার জামাই ইকবাল, তো একটা পোস্ট দিছে, স্যার কোভিড পজিটিভ নিয়ে ভর্তি হয়েছে।
তো মুশকিল এই বয়সে।
আল্লাহ ভালো
আচ্ছা, সবাই দোয়া করেন স্যারের জন্য।
আসসালামু আলাইকুম।
আসসালামু আলাইকুম এভরিবডি।